I am Kathy Thatcher, and today I will present the APN 760 Systematic Review on omega-3 fatty acids and triglycerides. Icosapent ethyl may be the preferred treatment to reduce triglycerides in patients with hypertriglyceridemia. The objectives of this presentation are to review the pathway of serum lipids, discuss the role of omega-3 fatty acids in cardiovascular health, introduce icosapent ethyl or IPE, present literature showing the effects of IPE on serum triglycerides and low-density lipoproteins, and discuss current findings and their implications for the field of nutrition and medicine. These are lipoproteins. They transport fats in our blood. As we age, maybe greater than 40 years, a routine visit to the doctor's office will include lab work. I am going to expand on the lipid panel and discuss types of lipids and their role in hyperlipidemia. Our focus today is on blood lipids, namely triglycerides and low-density lipoproteins. In the blood are three types of lipids: cholesterol, triglycerides, and phospholipids. They serve important functions. Cholesterol is used in the synthesis of bile acids, steroid hormones, and cell membranes. Triglycerides are important sources of energy, and they are stored throughout the body. Phospholipids comprise cell membranes and serve as emulsifiers. These lipids are transported in the blood via lipoproteins. There are four types: chylomicrons, VLDL, LDL, and HDL. At the top left, chylomicrons are made in the gut and contain some cholesterol and triglycerides. VLDL are produced in the liver and contain triglycerides and some cholesterol. Both chylomicrons and VLDL are transporters of triglycerides energy to the body. Once the triglyceride is released to the tissues, the remaining protein is made up of mainly cholesterol or LDL, and most of them return to the liver transported by HDL or high-density lipoproteins. If there is an insufficient amount of HDL, LDL can hang around in the vessels and create plaque. On the market today, there are several lipid-lowering remedies: statin medication, niacin, fenofibrates, and omega-3 fatty acids. High triglycerides and high lipids are associated with atherosclerotic coronary heart disease. They do this by adhering to the inner lining of the arterial wall, eventually narrowing the vessel wall. The wall then becomes sclerosed or hardened. The research question for this systematic review is: among adults greater than 18 years of age with hypertriglyceridemia greater than 150 milligrams per deciliter, what effect does icosapent ethyl intake, 4 grams a day, have on triglycerides and low-density lipoproteins? In treating patients with triglycerides, I wanted to know what the literature said about fish oil and triglycerides. So I searched for studies that test fish oil on triglycerides, and I found studies and systematic reviews of trials going back 10 to 20 years, but locating several recent experiments was difficult. In 2005, the FDA approved a combination of the omega-3 fatty acids, icosapentaenoic acid or EPA, and docosahexaenoic acid or DHA for the treatment of elevated triglycerides. In the U.S., dietary supplements of omega-3s contain both EPA and DHA. Since their approval several years ago, human studies revealed the desired decrease in triglycerides from use of omega-3s, but consequentially, they have found an unwanted elevation in low-density lipoprotein cholesterol or LDL. What we are learning from the past decade of human studies is that fish oil supplements can lower triglycerides at the expense of raising LDL. In 2012, the FDA approved a purified form of EPA called icosapent ethyl, or IPE, to reduce triglyceride levels in patients with hypertriglyceridemia. This highly purified EPA product did not raise low-density lipoprotein cholesterol, even in patients with triglycerides greater than 500 milligrams a deciliter. The review contains 4 articles. 2 of the studies are randomized controlled trials. The first one is titled The Marine, a 12-week study of men comparing the effects of IPE on triglycerides against a placebo. The second study is a post-hoc analysis from the Anchor trial. The Anchor trial was a 12-week study to determine the effects of IPE on the triglycerides of over 700 patients. The statin-treated patients of the Anchor had high triglycerides even with statin control of their LDL. This present follow-up to the Anchor was carried out to determine the effects of IPE not only on triglycerides, but on low-density lipoproteins as well. It involved 146 women with type 2 diabetes. The second set of trials included retrospective case studies that analyzed the charts of patients. The first study looked at the charts of 10 patients from a private endocrinology practice in Houston, Texas, who had been taking statins for cholesterol, along with omega-3 fatty acids, DHA, and EPA for at least 1 year. For the current trial, they were switched to IPE 4 grams a day for 3 months. Then the final study on the right that I examined reviewed the charts of 14 adult patients from multiple medical practices in upstate New York. 10 patients were taking statins, and 4 were taking another cholesterol-lowering medication called ezetimibe. As in the Houston trial, these patients were switched from omega-3 fatty acids, the usual DHA-EPA combination, to IPE, the purified ethyl ester. In both trials, the goal was to see if IPE could lower triglycerides without elevating LDL. I will now explain each trial in more detail. The Marine trial was a multi-center, placebo-controlled, randomized, double-blind, 12-week study to evaluate the effects of IPE in the adult male patients with very high triglycerides. I've included a triglyceride scale where we see that very high means greater than 500 milligrams a deciliter. The population consisted in 177 male patients from similar backgrounds who were divided into 3 groups. The first one, 61 males who would receive IPE 4 grams a day. The second group, 63 who would receive IPE 2 grams a day, and a placebo group of 53 members. After 3 months, the post-IPE treatment values were compared to the baseline values. For Group 1, who took IPE 4 grams a day, there was a significant reduction in triglycerides from 652 to 486. A light reduction in triglycerides for the subjects receiving 2 grams a day, and no change in the placebo group. A reduction in triglycerides was expected. You see, omega-3 fatty acids have been shown for years to reduce triglycerides in patients with very high levels. The LDL cholesterol dropped as well, except in the middle group where it was elevated but insignificantly. The Marine trial showed a reduction in triglycerides without a significant elevation in LDL. It was the largest omega-3 fatty acid study to examine the effects of IPE on triglycerides and LDL. The original Anchor trial that I talked about a few minutes ago was this 12-week, very important trial of 702 statin-treated patients with increased cardiovascular disease risk. This present study is a post hoc sub-analysis of 146 women, predominantly Caucasian, with diabetes type 2, triglycerides 200 to 499, LDL 40 to 99. The mean age was 61 years and the mean BMI was 33. All were taking statins. The decision to follow up with adult women of the ANCHOR study stems from the statistics of cardiovascular disease. Although cardiovascular disease-related death rates have decreased by nearly one-half among U.S. adults over the past few decades, there has been less of a decline in women than in men. As the incidence of type 2 diabetes increases in both men and women, women have a higher hazard ratio for fatal coronary artery disease than men. Likewise, elevated triglycerides are usually found to have a greater adverse effect on cardiovascular disease in women than in men. In this study, 74 women took IPE 4 grams a day for 12 weeks, and 72 women took a placebo. The 12-week results showed a significant 21.5% reduction in fasting triglycerides in women treated with IPE 4 grams a day compared with the placebo. Although there was no significant reduction in LDL cholesterol, it is important that IPE lowered triglycerides without increasing LDL. The analysis of women with high triglycerides shows improvement in cardiovascular disease risk factors with IPE, a DHA-free prescription omega-3 drug. Finally, EPA therapy was shown to be safe. These findings point to IPE as a beneficial treatment for cardiovascular disease risk in women with type 2 diabetes, and these are also comparable results to the Marine study previously reviewed. Dyslipidemia is common in patients with diabetes and prediabetes. All three conditions put one at risk for cardiovascular disease. Statin therapy is the first-line treatment for elevated lipids, but some patients may have residual risk of cardiovascular disease events due to the elevated triglycerides. The Residual Risk Reduction Initiative defines residual cardiovascular disease risk as the risk of cardiovascular events that persist despite achievement of LDL cholesterol, blood pressure, and glycemic treatment goals. For this reason, it is necessary to add omega-3 fatty acids. In the retrospective analysis studies, a medical practice reviewed the charts of 10 patients who had been taking omega-3 fatty acids 4 grams a day. After checking a lipid panel from 10 clinically stable patients, they were switched from IPE 4 grams a day for 2 months. The patients included 8 adult males and 2 adult females ranging in age from 42 to 66 years. As stated in the previous study, patients receiving statin treatment for dyslipidemia often require additional therapy to control triglycerides. Historically, fibrates and niacin have been accepted for treatment of triglycerides, but because they hold safety issues and unwanted effects on LDL, IPE is drawing attention. In this retrospective chart review, in 4 medical practices of upstate New York, it looked at 14 patients who had high lipids and triglycerides, no dietary intake of omega-3 fatty acids, and who were taking statins or ezetimibe. They were enlisted in the trial by first adding 4 grams a day of omega-3 fatty acid supplement containing EPA and DHA for at least 2 months. Then later switched to IPE for at least 2 months. Lipid assessments were performed before the lipid-lowering medication, while on the lipid-lowering medication, while on omega-3 fatty acids and lipid-lowering medication, and 2 months after the switch from omega-3 fatty acids to IPE. Here is a line graph of triglyceride levels while taking omega-3 fatty acids, the blue, and the orange represents the values after switching to IPE. For the most part, IPE lowered triglycerides and lowered them significantly in several cases. Now we look at the low-density lipoprotein values and see significant reductions. The blue line represents omega-3 fatty acids, and the orange represents the results after the switch to IPE. This is what the study was hoping to find. This real-world retrospective analysis of patients with hyperlipidemia demonstrated that switching patients from omega-3 fatty acids to IPE reduced triglycerides and LDL cholesterol. I've summed up the information through a visual abstract. See, IPE is an omega-3 fatty acid. It's a purified form. In 2 of the trials, it was compared to a placebo. Overall, IPE lowered high serum triglycerides 16 to 24%. It was also more successful at maintaining and lowering LDL, 8 to 53% in patients taking statins. In the studies comparing results of IPE 4 grams a day to a placebo, or monitoring IPE as a replacement for fenofibrate, DHA, or EPA, there is notable evidence that purified EPA in the form of IPE lowers the risk for dyslipidemia in both men and women. The FDA approval of IPE in 2012 allows doctors to prescribe an omega-3 fatty acid capable of reducing triglycerides without unwanted increase in LDL. Findings such as these point to IPE as a beneficial treatment for patients with comorbid conditions to reduce their risk of cardiovascular disease, the leading cause of mortality. I gave this systematic review some of the articles of a fair grading, and I will explain why in my limitations section. Here are some of the strengths as I see them. All 4 trials associate IPE with reduced triglycerides and unwanted elevation in LDL cholesterol. The Marine and Anchor trials are reputable trials with a large sample population. IPE is well tolerated with few adverse effects. Switching to IPE from omega-3 fatty acids was an effective method, and studies aimed at reducing hyperlipidemia in diabetic patients is important and worthwhile. The limitations are that the retrospective analyses use very small sample sizes. Patients had different underlying conditions. They took different lipid-lowering medication, and their lipid measurements varied on their time points. They weren't consistent with those. The Anchor post-hoc analysis was only designed to test IPE, but it was not set out to determine the direct effects of cardiovascular events. Switching over to IPE. And most of the studies were funded by the Amarin Pharma company, the manufacturer of the prescription IPE in the U.S. And since Amarin Pharma is the one licensed to produce IPE in the U.S. right now, it drives the price up. And so many doctors in the beginning might be reluctant to prescribe to their patients due to cost. The implications for research and practice are, while IPE is now known to reduce triglycerides without elevating LDL, future studies would do well to investigate IPE therapy and its overall effect on cardiovascular disease risk. Future research may study potentially hepatotoxic or hypersensitivity effects of IPE. Nutritionists who recommend omega-3 fatty acids should be knowledgeable about the purer forms of IPE and their implications and use in treating patients with dyslipidemia. And I might say that even the over-the-counter brands, some are better than others, and it might be helpful for us to become aware of the purer forms, maybe in health food stores, that we could recommend to our patients, rather than the Walmart or Costco brands. Patients with significant dyslipidemia and insufficient treatment with statins, DHA, and EPA should be referred to an MD for further monitoring and adjunct therapy with IPE. Thank you for your attendance. This page has references 1 through 6, and this page has references 7 through 13. In most cases, patients experience decreases in triglycerides and LDL after switching from omega-3 fatty acids to IPE. Evidence suggests IPE therapy improves the lipid panel.